Hello again, my friends. This will be our talk on the squamous cell carcinoma, particularly the cutaneous squamous cell carcinoma, because there are squamous cell carcinomas elsewhere, namely the lung and the esophagus. So typically when people think of squamous cell carcinomas, they think primarily of the skin because they're very, 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 very common. So we're going to talk about that. We're also going to talk about a couple precursor lesions that are associated with progression to squamous cell carcinoma as well. If you haven't had the opportunity yet, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can get there by clicking the link below in the description of the video or on the I button on the upper right hand corner of your screen, and it should link you up. If you consider chipping in $1 a month, a little bit goes a long way to help keep these videos free and coming. If you subscribe, you'll have access to some of my premium videos in which I go over case studies, formulating differential diagnosis, treatment plan, things that will come in handy for you if you want to impress your attendings on rounds or as you get ready to take USMLE Step 3, which has clinical case scenarios which are not multiple choice. Thank you very much in advance for your consideration. So here we are with our vignette for squamous cell carcinoma. Now, obviously, you know that this is going to be squamous cell carcinoma because it's the name of the lecture, but just keep an open mind to this. So we have a 70-year-old white man presenting with multiple hyperkeratotic scaly papules on the face, scalp, and hands. One papule on his lower lip has grown and sometimes bleeds. For most of his life, he worked as a soybean farmer. In the past, he has had significant sun exposure, including multiple blistering sunburns. Past medical history includes ulcerative colitis, for which he takes infliximab. Previously, he's had skin cancer on the face, but he doesn't remember what type it was. Physical exam reveals a 1 centimeter wide, round, roughly mildly erythematous papule, and with some hyperkeratosis. There is evidence of mild ulceration. So this guy has so many signs that point us towards squamous cell carcinoma that you probably don't even need to look at the lesion to know that this is squamous cell carcinoma. And I could see on the USMLE them giving you a very, very obvious vignette and then asking what's the most likely diagnosis without even giving you a picture, without even giving you histopathology, because this is such a classic case. So the most likely diagnosis here is squamous cell carcinoma, and just going down this vignette, he's a white guy, he's older, he's got a background of lesions. What are these lesions together called? This is actinic keratosis, otherwise known as solar keratosis, which is a precursor to squamous cell carcinoma. That's these hyperkeratotic, scaly papules, sometimes with like a yellow crust, can be difficult to tell from seborrheic keratosis. He's got progression of a lesion, so enlargement. He's got a history of significant sun exposure, occupational history. He's got a history of sunburns, which obviously is going to raise his risk not only for squamous cell carcinoma and the non-melanotic carcinomas, but also of melanoma. He's got a history of ulcerative colitis. That's not so much a risk factor, but the fact that he's taking immune modifiers, infliximab, reduces the immune system, increases the risk of squamous cell carcinoma. He's also got a history of skin cancer. He doesn't know what type it was, but you can probably conclude that it's one of the more common types. That might be a safe guess. And then he's got this large lesion that doesn't look like the others, kind of your ugly duckling sign that we talked about with the melanoma section. And there's also some evidence of ulceration. Also, it's on the lower lip. Lower lip is more common for squamous cell carcinoma. Upper lip is more common for basal cell carcinoma. For whatever reason, USMLE likes to test that. So you can put that in your back pocket. Best next step is going to be an excisional biopsy, and then ultimately, if it comes back positive, we're going to need to get clear margins. So squamous cell carcinoma is a neoplasm derived from keratinocytes. That is in contrast to melanoma, which is derived from melanocytes. There are a couple precursor lesions. One we already talked about called actinic keratosis. The other one called Bowen's disease, which looks very similar to squamous cell carcinoma. Sometimes it's really hard to tell. If you have Bowen disease, you may think it's squamous cell carcinoma. You get a biopsy, and in fact, you see squamous cell carcinoma, but it is localized to the epidermis, and so we call that in situ. It has not invaded the basement membrane, has not invaded the dermis, so this is in situ. Most squamous cell carcinomas will develop from one of these lesions, but they don't have to. Epidemiologically, this is the number 2 most common skin cancer, second to basal cell carcinoma. The exact numbers are difficult to estimate because this is so common. It's not reported to the cancer registry, but probably around 1 million cases in the US per year. I read somewhere 700,000, but that's probably, like I said, an underestimation. The incidence is increasing as we have an aging population, changes in UV exposure, a lot more voluntary UV exposure, people going to tanning beds and so forth. More common in white, people who are fair-skinned, particularly if you have red hair, blue eyes, that is going to mean you have less pigmentation in general. People who live closer to the equator, so think Florida, Southern California, and then men slightly more than women. Another thing, interestingly, is you have to take into consider elevation as well. So if you think of Europe, all of Europe, it's mostly white people in Europe, and roughly along the same latitudes. However, Switzerland has the most cases of squamous cell carcinoma, and that's probably due to their elevation. They're in the mountains, and so I was in Peru last month, and I was hiking up a few different mountains and got a pretty decent sunburn on my forehead. It was only April, and, typically that's not a time when people get sunburns, but you're talking 10,000, 15,000 feet elevation. So you're more likely to get more UV exposure when you're in higher elevation. Typically, this happens in older people. Presentation is around 70 years. It can happen in younger people. Again, it has to do with how much UV exposure you've had. And remember that UV radiation is a carcinogen itself. It's actually classified as a class 1 carcinogen by the International Agency for Research on Cancer, and that's the same class of carcinogens as asbestos. So this is a carcinogen. UV radiation is thought to deplete those Langerhans cells that are in the stratum spinosum of your skin. And those are thought to play an immunogenic role. So it basically makes your skin immunodeficient, and that's why it's thought that you get an increased risk of squamous cell carcinoma, in addition to damaging the DNA in your keratinocytes. If it occurs in kids, then you need to think xeroderma pigmentosum, a hereditary condition, raising their risk of various skin cancers. Risk factors, the big one is chronic cumulative sun exposure. Certainly sunburns would also raise your risk, but unlike the melanoma, squamous cell and basal cell carcinomas are more chronic cumulative sun exposure as opposed to short bursts like going into the tanning beds. Chronic wounding and inflammation, fair skin color, as we talked about, exposure to hydrocarbons, those polycyclic aromatic hydrocarbons, burns, radiation, immunosuppression, and xeroderma pigmentosum. The big one for immunosuppression are people who are organ transplant recipients who are on immunosuppressants. People who are organ transplant recipients, bone marrow recipients, people who are HIV positive, who have a history of autoimmune or rheumatic disease and are taking medications to that end, they all have an increased risk. And not only that, but people who are organ transplant recipients have an increased risk of death if they do get squamous cell carcinoma. It tends to be more severe. Some precursor lesions. So actinic keratosis. This is also known as solar keratosis. There are a lot of different clinical subtypes, but the most common way that this presents is a 2 to 6 millimeter erythematous rough scaly patch on a highly sun-exposed area. So think scalp, face, arms, forearms, neck. Sometimes this can develop like a horn, and that's a very obvious clinical presentation. So I imagine on the USMLE they may give you something like that, because actinic keratosis can look kind of like seborrheic keratosis, and unless you feel it, it can be kind of hard to tell the difference on typical presentation. So a lot of times on the USMLE they give you a really obvious case. So look for that horn, and I'll show you a picture of that. Risk factors and pathogenesis are the same for squamous cell carcinoma. The risk of malignant transformation is proportional to the degree of dysplasia, which obviously you wouldn't know unless you get a biopsy. It's extremely common. The prevalence increases with age, and often it's very difficult to tell apart from squamous cell carcinoma. Really good dermatologists can do it. If you're a general practitioner, you might not be able to. You might send them off to a dermatologist for a biopsy. Actinic keratosis is more likely to develop on chronically diseased or injured skin, so think places like burn sites, wounds, and stuff like that. Okay, I'll show you some pictures of actinic keratosis in a little bit. Another one is Bowen disease. This is squamous cell carcinoma in situ. And unlike actinic keratosis, the lesions are usually solitary. So this looks like a squamous cell carcinoma, and you really don't know until you get the biopsy and then you find that there's no invasion of the basement membrane, that this is just localized to the epidermis. The definitive diagnosis, both for actinic keratosis and Bowen's disease, is biopsy. And the treatment is typically the same for both of them. Cryosurgery, you can also use topical agents, 5-fluorouracil, and imiquimod. Imiquimod stimulates the immune system and will help with resolving these things. So this is actinic keratosis. If you've ever seen seborrheic dermatitis, looks very similar to this. The seborrheic keratoses as well. You get that kind of yellow crusty stuff that comes along a more erythematous area. The way that you can kind of tell actinic keratosis apart from squamous cell carcinoma is that you've got a wider, you've got multiple patches and areas that look pretty much the same. If one region of the actinic keratosis develops and starts to change and look a lot different from the other areas, then you know that you've got possibly something more malignant on hand. But actinic keratosis is very common on the scalp, very common in older people, but it should all look the same. And as far as telling it apart from seborrheic, it's really the main difference between actinic keratosis and seborrheic keratosis is that actinic keratosis doesn't have that velvety and greasy feel to it, whereas seborrheic does. So here you can see, again, kind of that yellow, crusty stuff. Again, on sun-exposed areas. Seborrheic will not necessarily do that. And you can see that you can also get actinic keratosis of the mucous membranes as well. This is on the lower lip. Remember that squamous cell carcinoma has a propensity for the lower lip. And when you develop it there, the prognosis is actually worse, as we're going to see. You can also develop it on the ear. Again, like the lower lip, if it develops on the ear, prognosis is slightly worse. Here's that horny appearance. So this is a very classic way that actinic keratosis can show up, but it doesn't have to. It can just be a flat plaque. But I imagine on the USMLE, they're going to be more likely to give you a picture like this because it's a very classic presentation. You can see here, again, kind of a horn-like appearance. So if you look under the microscope, histopathology for actinic keratosis will typically show abnormal keratinocytes, but they're always going to be confined to the epidermis. There may also be an inflammatory infiltration beneath, so you can see some inflammatory cells here. Also some underlying elastic tissue. We call this solar elastosis. In the papillary dermis. Note also these palisading basal cells. That's very classic for actinic keratosis as well. But all of the abnormal cells are confined to the epidermis. You have some changes of the dermis, but you don't have any abnormal cells down there. Now, Bowen disease can be kind of easy to miss depending on how it appears. So you have to pay attention to this. This is Bowen disease here, and you can see that this kind of just looks like a bruise. So you got to ask patients, if they come in or you see something like this, you need to ask them, how long has this been there? Because if it's only been there for a week, you might be able to say, come back, keep an eye on it, come back in, a couple months if it doesn't go away. But if it's been there for months on end, then this needs to be get a biopsy of this for sure, because this can easily go on to become squamous cell carcinoma. This is quite a bit more obvious looking. Bowen disease can look like this too. You can see this is always abnormal, this hyperkeratinization that occurs here. And there are two foci here, one down here and one up here. This is clearly abnormal. Patients should come in complaining of this. You shouldn't have to find this on your own. But again, you see the hyperkeratinization along the edges. Histopathologically, Bowen disease is basically squamous cell carcinoma that's confined to the epidermis. So what you see with Bowen disease is you see abnormal cells, but you don't see anything abnormal in the dermis. You may see a little bit of inflammation, but that's it. You're not going to see abnormal epithelial cells in the dermis. You're only going to see them in the epidermis. But notice that you do have a loss of architecture, of normal architecture. You don't see that stratification that you see in normal epithelium. Again, you see it here, little nests of keratinocytes that are not where they should be. So you don't want to see these little nests. That is a hallmark of squamous cell carcinoma or squamous cell carcinoma in situ, otherwise known as Bowen disease. And I do want to bring up one important factoid that may or may not come up on the test. I doubt it, but it's good to know. It's a 99th percentile fact. And that is if you have Bowen disease, something like this or like this, on the penis or on the vulva, it's called erythroplasia of Queyrat. Queyrat. An erythroplasia of Queyrat is just Bowen disease of the genital. And so in the penis, it can be on the glands or on the prepuce, which is the foreskin. So people who are uncircumcised have an increased risk of squamous cell carcinoma. And then it can also be on the vulva. And these are linked to HPV. So that's something that is useful to know. So as mentioned, squamous cell carcinoma, malignant neoplasm derived from keratinocytes. We talked about all this stuff. The gross appearance for squamous cell carcinoma looks very similar to Bowen disease, as we already saw. May present as a thin plaque or an erythematous scaly papule, often ulcerates. Most commonly, it occurs on sun-exposed area, face, arm, hands, and lips. So we got some pictures of squamous cell carcinoma here. There are actually two foci of squamous cell carcinoma on this gentleman's forehead. You can see that it's occurring on a background of actinic keratosis, and that's very common. Here you can see a lesion in the lower lip. This is a very exophytic squamous cell carcinoma, so they can appear like that. This has got notice how this kind of has a rolled border to it, and then this inner portion of keratosis, hyperkeratosis that you see. This is actually called keratoacanthoma. They're not always malignant, but this is a kind of a subtype of squamous cell carcinoma. So you see the rolled edges and this kind of horn-filled crater in the middle. Again, this is something you're going to need to biopsy. So they can also be flat. They usually are. They look really scaly, kind of crusty looking. As far as the microscopic appearance of squamous cell carcinoma, if you're given this on the USMLE, it's going to be really obvious. And there's two big things that you're going to look for squamous cell carcinoma. First of all, you're going to see these keratin pearls. And keratin pearls occur in all different kinds of squamous cell carcinoma. If you have squamous cell carcinoma of the lungs, you're going to see keratin pearls. You may see them in squamous cell carcinoma of the esophagus. So it's very characteristic of squamous cell carcinoma, but obviously you're going to know the difference on the USMLE just based on, clinical history. It should be fairly obvious on a vignette whether you're dealing with skin cancer or esophageal cancer. But when you have squamous cell carcinoma, you got to think keratin pearls, and you will see very obvious picture. If they give you a picture of the actual tumor, then they should make it pretty. It should be a pretty obvious difference between melanoma, squamous cell, and basal cell carcinoma. You notice, though, that some of the basal cell carcinomas and squamous cell carcinomas and even some of the melanomas can look pretty similar. So if they give you a picture of that, what they're probably going to then do is give you either a histology report, a pathology report, or they're going to give you a picture, especially if you're taking step 1. The histopathology is very obviously different between the three cancer types. So you look for these keratin pearls for squamous cell carcinoma, as well as intracellular bridges, which can be a little bit difficult to see, if not impossible to see, unless you've got a good magnification of these tumor cells. And remember, those intracellular bridges, those are just the desmosomes that normally appear in the layer of the stratum spinosum. So here's a microscopic view. You can see little tiny keratin pearls, but more importantly, you can see that these abnormal cancerous squamous cells or keratinocytes have invaded the underlying dermis. Here's an example of keratin pearls. You have to know keratin pearls with squamous cell carcinoma. It's a very easy point. Very easy point. Again here, keratin pearls, they have this sort of onion skin-like appearance. And then there's obviously an infiltration along the tumor. Anytime you have a cancer, you're going to have an immune response to it. And then this is the intracellular bridging that occurs. And these are just desmosomes that are linking these tumor cells. As far as history, look for chronic sun exposure, presence of risk factors, family history, certain cancers run in families, and squamous cell carcinoma is one of them. All the skin cancers, really, if you have a family history, you're at increased risk. And what that probably has to do with is just skin pigmentation and skin color. The symptoms are a growing skin lesion, which has been present for some time and has failed to heal. Maybe it's been there for a while. It was actinic keratosis, and now it's transformed into squamous cell carcinoma. There may be ulceration, so patients will say that it bleeds. Physical examination, remember to do a whole body skin examination. Keep a lookout for a background of actinic keratosis, which will often be present elsewhere. Always good to check for lymphadenopathy local to the lesion, as well as ask about constitutional symptoms. Even though they're rare at presentation, you may need to do some additional investigation if any of that is present, because squamous cell carcinoma can metastasize, much more likely to metastasize compared to basal cell carcinoma, as we'll eventually see. As far as diagnosis, typically you're going to first suspect it on appearance. Dermatologists do something called dermatoscopy. You won't do that if you're a general practitioner, but an excisional biopsy with margins is the best initial test and will certainly yield a definitive diagnosis. Differential diagnosis includes actinic keratosis, which we already talked about, Bowen's disease, which we already talked about, seborrheic keratosis. Seborrheic keratosis tends to be more brown, pigmented in appearance. It's texture-wise, it's kind of waxy. It looks wart-like, and it's got what's called a stuck-on appearance. It looks like you just took some waxy brown stuff and just stuck it on somebody's skin. Often it can be hyperkeratotic, but not necessarily. And then the basal cell carcinoma, if it's flat, it can be really difficult to tell from a squamous cell carcinoma. But if it's exophytic, it's got a much more pearly and smoother appearance. There's often telangiectasias. You may see the telangiectasias too, even if it's flat, so look for that. Histologically, it's much different from squamous cell carcinoma. If you watched the intro to skin cancers, you would have seen that the basal cell carcinoma, these are dark staining cells that invade the dermis, and it's got a very stereotypic palisading pattern. Squamous cell carcinomas are graded histologically using Clark's levels, which we talked about in the melanoma talk. They're staged via the TNM system. Don't worry about that for testing purposes. The treatment is a wide local excision, and then chemotherapy is available if the tumor is unresectable or if it's metastasized. There is a low risk for metastasis, so the prognosis is typically good. However, the risk of metastasis is much higher than for basal cell carcinoma, which has virtually a zero risk for metastasis. The prognosis is worse for larger tumors, deeper tumors, as well as tumors that occur on the lip or ear, and then also in people who are immunocompromised. We already talked about that. Squamous cell carcinomas, remember, tend to occur on the lower lip, whereas basal cell carcinomas tend to occur on the upper lip. Primary prevention is the same for like melanomas and other skin cancers. Avoid overexposure to sun. Always wear sunscreen, SPF of greater than 30. Wide-brimmed hats can be useful. Also for squamous cell carcinoma, niacinamide and retinoids may play a helpful role in preventing, especially if you've got a patient with actinic keratosis. They may benefit from this to reduce the risk of progression to squamous cell carcinoma. And as usual, self-checks can be helpful. So just to recap, squamous cell carcinoma is a malignant neoplasm of keratinocytes. The classic patient is old, fair-skinned, who has chronic sun exposure. Think like a farmer, a construction worker, somebody like that who spends a lot of time outside, usually with a history or presence of actinic keratosis or Bowen's disease. Often they live closer to the equator. Physical exam, crusty, thin, scaly plaque, but occasionally exophytic, as we saw a picture of, often on a background of actinic keratosis. Definitive diagnosis is biopsy, which will show keratin pearls and intracellular bridging. Just remember, please remember the keratin pearls. That will help you. It could be a very easy point on the USMLE. The malignant cells will invade the dermis, unlike Bowen's disease, which otherwise appears very similar on histopathology. Prognosis is associated with the size of the tumor, depth of the invasion, location. Remember, lips and ears are worse, and the immune status. And the treatment is a wide local excision with margins. Chemo exists, but you're not responsible for knowing the chemotherapy. It is typically platinum-based. However, there are, as for many of the other cancers, there's immunotherapy that is emerging. If you have any questions, please write me a note below. Otherwise, I will see you next time.